hospital in the oncology department. Right?
Yeah.
Okay. All right. So, yay. Thanks for coming.
Yeah, thank you. So just so I get a feel from where everybody is at, how many people are interested in doing like physical rehab? How many people are interested in doing mental health? Keep it up here. Keep it. How many people are interested in working with adults? Okay. So you should go there. And then who's interested in doing pediatrics? Okay, good. So my name is Heather Mankin. I'm an occupational therapist at Children's, and I've been an OT for a little over 15 years. And I've worked in every pediatric setting that you could possibly work as an OT. And I've had lots of different jobs and different job opportunities. I was just telling Sydney that I recently moved from working in outpatient onto the oncology floor. So as I was putting together this presentation, I didn't, I'm far from an expert because I'm like you guys. I'm just learning. So I would love to share with you kind of when I'm starting a new job and my journey is learning, which one of the best pieces of advice that I got when I was a student is never stop learning, and that is so true. I learn every day, every year, and that is what is so amazing about this profession is there's just so many different areas that you can go into. So the first question that I'm posing out there is, why is occupational therapy an essential role in pediatric oncology? This is a new developing area for OTs to work. Previously, there were no any type of therapy. Physical therapy probably in many ways leads us, and probably about 10 to 15 years ago started making headway into oncology work and started working on doing rehab and started putting out research. From there, when there was component areas that were blaring, like a patient was having trouble swallowing, obviously then they started recruiting speech therapists and occupational therapists. But before, patient was diagnosed, they went into treatment, and then afterwards, if they made it through, then they looked at doing therapies. So with the pendulum shift with physical therapy, seeing that they actually got better outcomes, and it's very prevalent on the floor that I'm on. Physical therapy is a much more dominant force than occupational therapy. So I'm really learning to develop what is the voice of occupational therapy. And going and telling how we are different from physical therapists and why there needs to be 2 referrals. And the big aspect of like what we do differently is the looking at the role of meaningful occupations and a person's ability to participate in that. The beauty of oncology is you're not just doing physical rehab, you are also adding that psychosocial piece, because I am looking at the roles of the parents, roles of the siblings. And that's very unique to the other disciplines because they tend to look more centered just on the patient. When I go in the initial lineup of, meeting a patient is there's a big acceptance process of a disease that could be life-threatening. And the survivorship has changed dramatically on oncology and pediatrics. For patients that are diagnosed with leukemia, it went from like a 40 to 50% likelihood of survival in the 80s up to 90, between 80 and 90% now. I'm going to use the word survivorship a lot. I want you to question that word. Because survivorship means just that. You survive. You still have a pulse, you're still breathing, and you're at different markers. Another type of leukemia called AML is has a much lower survival rate at 5 years, and I think that's down to like 60%. Some of the solid tumors like lymphoma or astrocytoma, you are dealing with up in the 80% survival rate for many of those. Neuro-oncology, that's another one where there's been a huge change. In the 80s, you were dealing with a 25 to 30% survival rate. Now, if you have a medulloblastoma, which is the most common brain tumor in children, you're up to 80% survival rate at 5 years. So there's been a huge pendulum change of like, now we're having all these kids that are surviving, and that's very exciting. So when I walk in, and typically referrals happen soon after the initial diagnosis of the family, we go in and we're like, you know, what is important to you? And really in that first interview, it's not, the child typically was developing normally. They didn't have any concerns. Maybe they got a little sick. So it's not like you're going in and you're diving in to get in all those component areas that you learned about in school, because there's not a lot of deviation at that point yet. Some kids come, unfortunately, with their comorbidity is developmental delay. So they may have already had therapies in the past or still having therapies. But getting that essential occupational profile is really so essential in helping me with create the roadmap of their journey. Kids are in treatment, depending on the type of diagnosis, anywhere between a year to most commonly 3 years to beyond. There's a, so I get the information from the family, I kind of get the information from the medical team, and then we kind of get to work on how occupational therapy can support those meaningful occupations and help the family with creating what the new norm is. Another area that occupational therapy is really a bit different on is many of the treatments, unfortunately, causes a lot of changes physiologically to the child. So, all the things on the television about St. Jude's with the very adorable child with no hair who's smiling, that's the common one that everyone thinks about. Oh, you're going to lose your hair. And that is one side effect. And so for teenagers, how does that affect them as they go through that period of time, and what ramifications that could have? Kids that have solid tumors where they have to have amputations, there's a big, huge body change. And so those are more the overt ones that are easy to identify. One barrier right now in the work that in oncology is they are using medications that were designed for adults, and they're giving them to kids. The toxicity of the medication is actually at a higher level than they would ever give an adult. And it's amazing, these little bodies, they are able to handle those treatments much better than any adult would. We would actually tap out much faster. But that has helped with overall treatment and also overall survival rates. But when you have high toxicity, it's a neurotoxin too. So then you get into other type of challenges. So at the very beginning, I'm assessing, where they are in their developmental stage, planning for the future, because there is a likelihood that they have a greater prevalence of the possibility of learning disabilities. And where OT kind of can fit into that is looking at those visual perceptual skills, those executive functioning skills, and what are those precursors that happen earlier on that maybe we can help facilitate to decrease the magnitude that may happen after treatment. The other big one is vincristine is a commonly used chemotherapy drug. It causes sensation changes, numbing, tingling, and tremors. So many, like when I work with school-based therapists, that's one thing that we're talking about, how is this child going to be able to complete their writing and typing now that they have this? And there is no treatment that helps with time. Some of the kids will return to function and will have no residual. Some kids have, and that'll be just varying degrees. And for a small percentage, it's pretty impactful. So it was very easy for me to see why OT was now put on the floor. And a lot of my daily work is doing just what I'm doing here. I talk about what role I can do. So hopefully we can increase our referrals so that we can build up the number of therapists that are working on the floor. Currently, up until 2 months ago, there was only one OTR. So there was, and we probably, our caseload, that not every day, but we managed probably about 130 patients. So it was a lot of juggling. Now there is a COTA that has been hired that is helping. So that's really nice. But we're hoping that our long-term plan is in the next 3 to 5 years that we can have a couple more. Yes. I forgot to say that. Okay, well, to put it, so the next big question that I think that sets us apart is always the utilization of what frames of references you use, that they pound into you in school. It's actually great. So I didn't understand the point of frames of reference probably as a student as much as I do now as a clinician. It's a really beautiful foundation of developing the most efficient and effective treatment. And so the frames of reference that is typically used to me are based on what occupation performance area I'm really trying to hit. The big one, and probably the one that governs most of, like as the big umbrella, would be I use MOHO, Model of Human Performance, where what we do know about kids that are going through intensive type treatments is there is a change in their play, because many times their affordance of going out and playing on the playgrounds and with other kids decreases. And for a lot of the kids that I work with, they're stuck in their hospital rooms because they're on some type of precaution. And so that kind of really starts changing the play dynamic and the development of those skills. It also increases, there's another thing of anxiety. It's a high anxiety floor. Families are anxious, kids are anxious, we're anxious. because we're in this journey with them together, and so we know what it's like when I just had a patient who went through, and they have a new type of treatment with immunology, which is extremely exciting. It's called CAR T, in which they create T cells to go attack the cancer cells. It was experimental and not FDA approved until I think 18 months ago. And there was only like a handful of facilities around the country that was doing it: Boston, St. Jude's, Seattle Children's, and Texas Children's. Starting last year, Colorado Children's started. And so I think there's 8 kids that have gone through the program. So it's really, really, really new. So speaking of anxiety, there's a lot of it as they, want success. And anyway, he's 64 days out, and they just found out that he has like no leukemic cells at all. It is 0, and they were able to detect the T cells are still there and still doing their job. So it was like an amazing win for everybody and as a team. We all felt the excitement of that, but teaching anxiety or how to address anxiety to a 2- and 3-year-old is challenging. However, and this is where I was talking to Sydney beforehand, is prior to going to oncology, I was an SI therapist, and talking about arousal levels and modulation, all those skills that I learned from that area, I have brought with me, and I'm utilizing a lot of those when I'm working with these, especially younger kids, on teaching, how to overcome the anxiety of all these procedures. The other one, I'm not going to let them out, Child Life is amazing. And if you guys work in facilities with Child Life, get to know them because they have great strategies that I totally pirate and take with me and put in my tool bag. The other big one that I use a lot of is a rehabilitative biomechanical based model. So treatment never is textbook. The roadmap is pretty, but it's in real life, it plays out differently. Once you pound your system with all this medicine, you're so immune compromised that illness happens. Many of the kids that I work with end up in the pediatric intensive care unit, and then we have to fight back. And with that, I'm definitely shifting. And with my teammates, we're using more of a rehabilitative model of intensive daily therapy to help get improved strength and endurance. Very rarely, probably when I'm tired and I just want to get my goals done, do I write a self-care goal. Most of them are play-based because that's what's most meaningful. If you think of that, you don't know if you're what the longevity of your life is going to be. How important is it for you to be able to, as a 4-year-old, to pull up your pants? It's probably not high on your list, especially because there's all these adults that live in your room now and can do it for you. The other 2 models that I frequently use, and this is more with kids with in the neuro-oncology, has to do with motor control, using NDT, PNF principles. As a neuromotor therapist, I probably have shifted a little bit away from adhering solely to those principles I'm sure as you learned in school, the literature is right now on the efficacy is building, and some people could say it's on the weaker end. I think that if you look at some of the motor learning principles and kind of combine the two, you can really get some nice returns. And I also use a behavioral model, especially for the hemiplegia kids, and that's in the venue more of using a constraint-induced movement therapy, which by far, even with neuro-oncology, is probably the most efficient way of getting return and improving the best capacity of the hemiplegic side. All right, I'm gonna take a pause. Does anyone have any questions?
I have a bunch. No. Do you feel like, so for when you're assessing roles for family and the clients, are you doing an informal interview to kind of gain an understanding of those? Or do you just like evaluate them as you go through the sessions? How are you establishing the change in roles, I guess?
I would say all of the above. There is not really good measures out there, outcome measures. I would say that does a perfect job of pulling that information out. So it is an informal interview of what's going on, but teaching like the interplay and the interactions between a mother and a child, or a father and a child, I should say, parent and a child, especially when it comes to discipline. You know, how would you discipline a child that may not live more than a year? You know, do you feel that you can do those things? So there's a complexity that I don't think that you can really pull out in like a measure, but it is a lot of informal interviews at this point, and utilization of the team members, the social work and child life and other teammates in nursing.
Do you follow the child through the continuum of care? So if they go to the ICU, you are still their therapist?
I'm their therapist while they're in treatment.
Okay.
And I'm going to get into in the last section, but one day I would like to look further down the road. But right now, the way our program is developed, from when you're diagnosed, I'm the OT that comes aboard, and then we follow them until they're finished.
You said it was kind of a newly developed area for OTs. Did you kind of just go to somebody and say, I think we have value here, and then they said, okay, and you came on, or did they have that in place already? Like, did you talk them into letting you do that, or?
No, I'm on the shoulders of someone else who had a beautiful idea. So I would say that you could go to any hospital for adults and children's hospital for kids, and there are very few therapists that are solely devoted to work on oncology. You know, they're doing everything else, and then all of a sudden, because oncology is a chronic acute situation, you know, then they kind of get pushed to the side. So the new idea is we're going to make this a priority, and then they're going to get a set amount. So that's, I would say, is new. The physical therapist that actually started the rehab program for children's came from St. Jude's, which they already have an established program, and they brought it to the attention of the director of our bone marrow transplant team, and they trialed it for 6 months, and then it grew from there. So I really think there is, and when you go into a working place, you'll find holes. The idea of therapists, like back when I was going to school, it was somewhat newer of therapists being in the NICU. Now it's like common practice, and people couldn't imagine it any other way. And if those of you that are interested in feeding, not my favorite thing to do, but we need people out there. With dysphagia, before that was like a domain where it was like, dietitians were kind of doing it with a little bit of speech therapists coming in, and now, there is an amazing partnership with all parties. So, any other questions?
This is more logistic, I guess. So you balance about 100 patients. How long are your sessions with them?
However long it takes. So, I would say, on average, it's like an hour. Some of the kids that are inpatient can't last that long, so it's like 45 minutes to 30 minutes. Depends on what we're doing, where they're at. But I have treatments, again, if I'm using a constraint model or even a motor learning model for my neuro-oncology kids, I have 2 other treatments for that. Evaluations, you're meeting families where they are, and they can last anywhere from 45 minutes to several hours.
How often do you see the kids, patients? Like, I feel like in like acute, you would see them every day. Do you really see them every day, or?
So it depends on what is their identified occupational need from their occupational profile. So if if you need more of a rehab model, you're seeing every day. If you are coming from more of a strengthening model, in the literature, they're saying at least 3 times a week. So they're seeing 3 times a week. Developmental, like you're just monitoring because we know that prolonged hospitalizations can impact development. Those are using more of a early intervention coaching-based model. So maybe they're seen once a week. I favor intensive models for almost all deficit-based areas. And so many of my kids are seen for a block period of time until they acquire that targeted skill, and then there's typically a break in between. So some kids are seen on a monthly to quarterly followed.
What are some common roles?
I don't know if I have a common goal. That's a really good question. I think it would be, so a goal for a lot of it's play-based and engagement in play. So for kids that are like with the most common form of childhood cancer is leukemia. And I would say that fatigue is probably the greatest impact or player. And so play duration, being able to play, get out of bed and play, play on multiple surfaces. So I probably have a lot of goals that are around that. Older kids is more of identification of teaching breath, visualizations, kind of addressing some of the anxiety aspects. And the neuro-oncology kids would be probably a typical neuromotor type based goal. It has to do with the quality of emotion.
You see babies ever? Is it a lot, or what's like the average age that you see?
I think it changes monthly, unfortunately. So, but yes, I worked with 2-month-old on breastfeeding. It's beautiful. But what's the problem with chemotherapy? It's fatiguing, and breastfeeding is so energy. It takes a lot of energy for a baby to eat. So what I did, and going back to what my goals were, is that they would have a full feeding session, and what my intervention plan was a lot about posturing or positioning of the baby to put the baby in the most ideal position, for arousal. So we had different techniques that we used to help wake the baby up a little bit more so they can eat better. And then we worked with the medical team because he had supplementation too. Any other questions? So I have a third area, and this is where my last kind of breakdown of like where I am currently and hopefully where one day we'll go. And also, if you're a therapist out in the community, it's important information. So I predominantly work on it in an acute situation. They were acutely diagnosed, and I'm dealing with those type of interventions. But what actually drew me to going to oncology was the idea of survivorship. I read an article. I'm an avid reader, and especially into research. And so one of the articles that I read talked about what survivorship really meant. And the numbers are pretty staggering. 6 out of every 8 kids survive who get past that 5-year mark have lifelong chronic disabilities. And to me, that's a pretty high number. And I was like, what are we doing for them? And I was on a multidisciplinary evaluation team through Children's Hospital that I worked with a neuropsychologist, a learning specialist, a physical therapist, myself, and a social worker. And it was a lot of kids that are struggling in school, and it was our job to find out why and then also develop strategies for the school to help this child with learning. And we happened to have a bunch of kids that came through that all were earlier diagnosed with and were treated for childhood cancer and were having these challenges. And I was like, well, why weren't you told? Why wasn't this like how to put in place? And so I ultimately would like to move and shift more to the survivorship and work more on the chronic side. But I can say from like the kids that I have interviewed that have moved on to that category of survivorship, many of them are working with school-based OTs because they still have a tremor, they still have fatigue, they still have nausea, and that has gone with them. And so those type of accommodations are still being made. But my question is, could we do something earlier so that there isn't that lifelong disability? Or how can we better educate families on things that they can try so that their child doesn't have to feel that they fail before they get assistance? All right. It's me. Any other questions?
Where else have you worked besides sensory integration and oncology?
I have done, so in school, my focus was on neuro rehab and sensory integration. And so my first, I worked adults with traumatic brain injuries. I've done early intervention, schools, and outpatient.
Everything.
And I've done patient. Well, thank you. Thank you so much.
Thank you. Thank you so much for coming.
Good luck to everybody.
Thank you.
Do good things for our profession.
That's the goal.
For every,
If we can get there.
people get there.
All right. Hold on 1 second. I'll switch gears. Maybe. Emily and Sarah brought snacks. Do you want to pass them out?
Sarah?
Yeah.
Can we get check with somebody on the tally if you want to step on that?
Yeah, you can check with me. Well, I'll try and go with this really quick.
You never know. Okay. I got mine free side. You wrote that? Yeah. You never know it's me. I'm gonna watch it. I my set.
Okay, I think I'm gonna get started on this stuff just so I can get you guys out of here on time. Her. I don't have a loud voice. Snap. Thank you. Okay, so I'm gonna go through everything really quickly, just so you guys get out of here on time. If you have questions, don't hesitate to reach out to me or Sydney or Sarah. Okay, so I have a slight update for Dean's reimbursement. We're gonna have you guys complete the requirements by April 22nd. And it would be helpful if you guys keep me up to date on what you're volunteering and if you've watched the meetings, so that we are all on the same page. Still 8 hours, your dues paid, and by April it's 6 out of 9 meetings because the 10th meeting is in May. So yeah, that's a change for that. Honor scores are the same. Maybe, I thought this would click on here. Okay, and Sarah's gonna talk really quickly about conference. We'll have more information in January, so it'll be a quick snapshot.
This is super early information, so don't freak out if we don't go over everything on this. But pretty much it's the 4th through the 7th. It's in New Orleans. If you're planning on going, start looking at plane tickets and Airbnbs or hostels or wherever you want to stay. Per day as a student rate, it's $200. For the entire weekend, it's $300. Last year, Dean's reimbursement was $200. We don't know what that will be yet, but again, that's to come. And then the link for conference is right here, and it has stuff like, it pretty much has all this stuff on it, and then it also has like what to do in New Orleans and all that stuff. So, yes. Out of everyone in this room, who's all interested in attending?
Woo, you guys rock.
Oh, is that did every single person raise their hand?
Yeah.
Okay, then I don't need to count. I don't need to count. Awesome. So yeah, start planning for that and looking into flights and talk to your friends.
Let's just get a big mansion.
Oh yeah. Yeah, and if you guys have
OT
questions, you can look online, obviously, or you can reach out to Sarah or myself or Sydney. Yeah, but we'll go over a little bit more in January.
Yep. Okay.
Thank you. Okay, so the volunteer stuff is all the same. There's the Rise Holiday Dance. That is the 21st. And then the gift donation, if you guys brought them today, you can bring them over to me. If not, we can work out tomorrow or over the weekend. Adaptive rec opportunities in Fort Collins. If you do that, just email Sydney that you did it. And then the Sports Buddy holiday party is the 8th, which is Saturday, right? Saturday, yeah. Wow. Do you want to give like a quick little spiel?
Sure. That's a nice.
I don't care, whatever you feel.
So Sports Buddies, it's with Big Brothers, Big Sisters, so a lot of one-on-one mentoring, but the Saturday is like the biggest event of the year. And it's at the island, so it's a ton of volleyball, indoors, of course, because it's cold. But it is awesome. There's like going to be over 100 kids and a ton of volunteers, and they all get presents and get to hang out. 10 to 2. Yep. So it's super fun, and yeah, it's just
Do we need to like sign up or anything?
Email me.
Yeah.
Email
Where at? It's at the island in
Aurora,
Aurora. Yeah.
the Denver area.
Yeah, it's like east of the Texan. Yeah, it's like Aurora.
Yeah, that's Aurora.
Yeah, it's super fun.
What are the ages of the kids?
It's all over the board. I think it starts 5 and 18.
Thank you, Kim.
Can I just get a raise of hands because I forgot to make a sheet? Who is interested in the Rise holiday party?
You made it last.
I know, but I just wanted to see if anyone else wanted to go. Interested, anyone? Okay.
Where in Lakewood is it?
It's like a little bit. What is that? Hold on, southwest of here. I'm thinking. Probably, yeah.
It's really fun. Colfax.
I wish I could make it. Yeah. I know, and that one's over the break, so I understand. I don't blame you.
And then sports buddies. Who's interested? Whitney. Yeah. You signed up.
Yeah, Whitney.
Wow.
I did it for an hour.
Okay. Anyone else?
I would love to, but
Hey,
Cool.
And then, sorry, go ahead.
If you change your mind, please let me know.
And then for Pizzaabilities, if you go, just make sure you tell us because we're not there every time. Karina's there a lot.
Lately, it's been 10 to 1.
The Pizzaabilities? Yeah. Perfect. I'll change it. Come on.
Double time.
Yeah.
No, but they
'Cause
opened
you-
at 9 by the time I got like 9:15ish.
Yeah. I think coming a little bit later would be beneficial because I think every time someone's waited.
Opening.
Yeah.
But it's so cool.
Yeah, it's really fun. It's a little social hour. Okay, and then I forgot to change the slide. Sorry, I'll send an email about it. But so we're gonna have Wednesdays from 4 to 5, I believe. I'll send it in an email, but it'll be Wednesdays 4 to 5, the last Wednesday of every month. Probably in the same room, and I think we'll still have. Do you guys like guest speakers?
Yes.
Okay, I think we'll still do guest speakers the whole time. January we might talk a little bit more about conference, just so you guys know a little more.
And if you guys know anyone of an OT or even a PT or speech therapist, we'd love to have them come speak. So just let us know their contact information and we'll contact them.
Or if you
always
haven't-
looking for people.
Yeah, if you have an interest area, we can reach out to people too. We obviously like peds, so we've reached out a lot to peds. I'll try and divert. Okay, and then if you are watching online, send break to Emily for your attendance. And I think that's a wrap. Do you guys have any quick questions about things?
I do have an announcement.
Hit
if
it.
you're interested for CUSOTA, for the conference, if you don't want to, I guess we'll talk about more about this stuff in January, but I have info about volunteering there, and I'll send it to you. Okay. Never mind, that's
Well, I'd like to hear it.
it. December 12th.
January.
Yeah, 'cause by December 12th, they open up the list where you can sign up to volunteer. And basically what it is you can go and sit in for free. Not the entire thing, but you're monitoring, but you're just literally counting hits. But you can listen to the speakers without having to pay for the ticket. And then if you do 4 hours, you get a free entrance into their expo where all the companies that you buy stuff from or are interested in talking to. That's pretty much what the expo is.
They're free things.
Yeah, they give out a lot of free things. And like they try to hype it up for everybody that's there. So it's like a circus, but it's super fun because it's all OT circus. So
And I think you can kind of make it fit your budget, if that makes sense. So like if you go there, you cannot go to as many workshops and pay less, but you're still networking, you're still getting to see some of the seminars and such. If you have more money, then you can go more things. So you can make it fit.
and I went last year, so if anybody wants to know personal
I want you to talk in
stories-
January.
Oh, just
Maybe you'll be our guest speaker.
You'll be our guest
But
speaker.
yes, of course.
Okay, cool. Thank you guys.
Yeah.